Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Hello and welcome back to the Sit and Stay podcast brought to you by RipsyTech. I am RipsyTech's product manager, Parker Anderson. As always, I am joined by RipsyTech founder and CEO, Tom Tarshis. Hey, Tom.
Hi, Parker. Good to see you today.
Good to see you, too. It's different today. Today is Friday. We usually record on Thursday, so different energy coming into this podcast. I hope the listeners look forward to that.
Yeah, and I'm feeling a little shameful for if anyone's watching this on a video podcast, they will see that I'm in a usual dress down video game type t-shirt, and Parker is looking very, very professional, putting the CEO to shame.
I appreciate that. As I explained to you before the recording, I put on a nice shirt today to emulate a feeling of productivity. I wanted to go in today getting a lot done, and I felt like, I wore a t-shirt yesterday. If I wear a nice shirt today, then maybe I'll just become the productive professional that I'm aiming to be today. So that was the goal, but if you're watching on video, you'll also see my Metal Gear Solid posters behind me, so still got that video game flavor.
There you go.
So before we dive into this week's episode, quick updates on RipsyTech. We provided a course on how to start a private practice on our website. If you go to ripsytech.com/practice, this is a course that we put a lot of effort into to help anybody who is kind of on the fence about starting their own practice, provide them with all of the tools that they need, take all the guesswork out of the experience so that they can launch with confidence. So if that is you, please go check that out again at ripsytech.com/practice. Okay, let's dive into the episode for this week. Last week, we talked a lot about legislation and why providers should really care about legislation and why, insurance might say, hey, we have this new rule, and then providers might band together and say, well, hey, maybe we should have some legislation to protect us from these kinds of crazy rules coming from the insurance and everything in between. So this week, we wanted to talk specifically about mental health parity law and really just dive into that. So let's talk about it. What is mental health parity, Tom?
Yeah, and I think in this context, we're going to go back in time a little bit for the history of mental health treatment. And in different podcasts, we've talked about the good news of decreasing stigma, increase in rise in providing services for mental health treatment. But if we drop back to the age when commercial insurance and other insurances started, mental health treatment, the field of psychiatry, it was something that was highly stigmatized and not talked about, and people were shamed if they sought treatment for depression or anxiety, and that opened the door for commercial insurance to not provide coverage for psychiatric or mental health conditions. So even back to when I first started the nonprofit, there were whole separate guidelines around many commercial insurances had no coverage for psychiatric diagnoses. Every single one had different levels of coverage for psychiatric versus non-psychiatric medical care. And it wasn't until the federal passing of mental health parity law back in the late 2000s, which we talked about last episode, that started to bring this issue to the forefront. There is still a long way to go, but when I first started our practice, even the billing codes that you used in mental health were not the same as other medical providers. So there were, the insurance company would say, we'll cover these 5 diagnoses only, and other ones we won't cover at all, or we'll cover with far less reimbursement, and you'll have to complete an authorization call every 2 weeks, or there were all of these extra conditions on getting medical care for mental health issues that other providers of care didn't have to go through, hence the problem with mental health being on par, or that is where mental health parity comes from.
Okay, so that was in 2008, correct?
Yeah, so the federal law came out 2008, and that put some federal mandates on providing the same, if sort of, hey, commercial insurance, if you're providing coverage for medical issues, you also have to provide it for mental health conditions. And it began to address some of the issues that go into mental health parity. But Parker, as you can imagine, the healthcare system and treatment is so complex, so that telling an insurance company, hey, you have to provide the same care standard is not good enough. And what you need are very specific phrasing and items to bring to the insurance companies. And I can give examples of those, but let me pause for a sec.
No, that actually, I'm curious. Like, let's hear those examples.
Yeah, so besides insurance companies, you being able to use your insurance card, the first issue is if you're calling to get your kid to a pediatrician, it's pretty easy to call and make an appointment and find a pediatrician who has openings. If you're trying to get your kid in to see a child psychiatrist or a therapist, there is not that same ease. So for parity, it should be exactly the same to go take your kid to a pediatrician as it is to go for a mental health professional. That was certainly not true then. It's still not true now, but that's an example of something with parity that it is still not parity.
Okay, so this was 2008. Now we're in 2026, and yeah, I mean, we talk a lot about how there are still barriers to receiving mental health care even in 2026. And these parity laws went into effect about 18 years ago. So like you're saying, we're still having these barriers. That's not really parity if we're still struggling to find a child psychiatrist, for example. So what's going on? Why do these barriers still exist?
Yeah, and there's many reasons here. Jumping to illustrate this through some examples. So in California, we had some good legislation passed a few years ago called Senate Bill 855 that did a bunch of things to get parity closer. It addressed appointment times so that you have to be able to get in for urgent care within 10 days, emergent care 48 hours, and regular routine appointments also have time for an appointment. It addressed distance that people have to travel, both by miles and by time to get somewhere, and so another parity issue. It put in place safeguards around in-person versus telehealth, so mandating that you can't providers that only provide telehealth services don't count as being good enough. You need to provide in-person services as well, as is true as you can get for medical care. So those were a bunch of things that bill addressed, which has been helpful. But Parker, I'd say the biggest fight, there's two issues here. The biggest reason why mental health parity still doesn't exist is because no one is telling commercial insurance companies how much they have to pay people for delivering mental health services. And until there are laws around reimbursement that make that amount fair, that will pull the 50 or 60% of mental health professionals who don't take insurance to start taking insurance, we will never truly have parity. So the reimbursement topic, and I want to talk about some landmark legislation that has gone through. I will say the second piece, which will even be true with this landmark legislation, unfortunately, is how's the enforcement going for these laws that are in place? And from repeated personal experience, the enforcement is, we need innovative strategies to address this.
You're right. I mean, I imagine it's hard. You can pass something and say this is the way things are now, but then, how do you make sure that everybody is aware of that change? I don't know. If I'm an insurance company and I've got people who are acting like things are honky-dory and exactly as they were before, other than, I don't know, an audit from the legal department or the justice department, I don't have a ton of incentive to go against the status quo. I don't know.
Well, add your company with billions of dollars of profits.
Right. And then you get a legal fine, and it's like, okay, we can do this illegal thing because the amount of money that we stand to make from doing the illegal thing outweighs the amount of money that we'd be fined for doing the illegal thing. I don't know. That's what I have a kind of a cynical view of a lot of major corporations. But yeah.
Yeah, and so you can Google Kaiser. You can Google any insurance company and see the lawsuits from not complying with some standard, and even with quite substantial fines, it doesn't necessarily affect these companies' bottom line. In addition, oftentimes these laws are passed, and then with the law, and the insurance company needs to prepare a report on how they're doing. So, there are outside agencies then that look at the report, and there was a report just released for California that shows multiple violations, but it's sort of, hey, here's all the things wrong, illegal that you're doing, fix them, and we'll come back in a year and see how you're doing. So that I think is something for a different topic.
Okay.
I did feeling good about the world, and we talked about this before, on some level mental health legislation is bipartisan support, which I really like in our divided world, that this tends to happen. And I've been following this bill that a colleague told me about in Illinois. It's House Bill 1085, which is landmark legislation because a lot of the parity issues that still exist, this one is pushing on. And most importantly, that reimbursement piece that we talk about, that's critical for providers and for what Ripsy's trying to help people do with start a successful practice. And so, yeah, I want to cover a couple of those points and use it as a case example.
Yeah, let's talk about it.
All right. And people all legislation, every state has a list of the legislation that people can go to. Just to pull up the voting, right? So in Illinois, there's a House and a Senate. In California, there's an Assembly and a Senate. So I think states are different here. But for the voting for this bill, so from the vote from the House roll call, there was 86 yeas and 19 nays. So very strong support. And then from the Senate vote was 48 yeas and 10 nays. So it passed very strongly in both the Illinois House and Senate. And what this bill does is it addresses a couple of big pieces in parity. And even by talking about these, there's other. So it does set this minimum payment floor. We're going to hold on to that one and come back to it to talk about what that actually is. But it requires same-day coverage of multiple medically necessary behavioral health services, even if provided by the same provider. So Parker, you may remember this. This is an issue. If you see a patient at 10 a.m. and then something goes awful and they want to come back and see you at 4 p.m., sorry, Charlie, insurance doesn't pay for 2 visits with you on the same day. Right.
So this would change that.
This would change that.
Oh, wow.
That's huge. It requires coverage for supervised trainees. Now, some insurance companies do this, but this is someone on their way to being a mental health professional that is supervised by a licensed provider that right now most commercial insurance companies won't reimburse for this. The law is mandating that you do have to reimburse for this workforce, which is huge. And if they're on their way to their license and properly supervised, it will go a long way in increasing access to care. Stop me at any point, Parker, if you like.
No, keep going. I want to ask follow-ups about the payment floor, but when we get to it.
There's only three more. It speeds up insurer contracting with behavioral health providers. So California has a law that went into effect this year that they have 90 days to be credentialed or they're assumed in network. Illinois has made it 60 days. And really, this should be like a week, Parker. When we started and had to mail physical things, etc., okay, we need extra time. But let's be real. With electronic verification of licenses, the ability to look up if a provider has done something bad, and the only reason that something takes 60 days is extreme disorganization or it's a delay tactic to deny care. But okay, 60 days. I think that's the shortest mandated time that exists. It allows retroactive in-network reimbursement so that if you come to see me and I say, hey, we've applied to be in-network with your insurance, and then we do get in-network, that family can go back and get that visit covered, even though you're out of network at the time. From the day we submit the application to be in-network, you could go back and get reimbursed for it.
Okay, wait, quick question about that, because if I'm a provider and I hear that, I'm thinking like, well, maybe I still don't want to risk it if I don't know if I'm officially going to be in network. Like, I guess if that process is started, but you're not officially in network yet, should I still feel kind of confident that will go through and that I will be able to get that retroactive reimbursement for my patients?
This is the beauty of this bill, though, Parker, because you're right. In any other state, anyone who doesn't have a criminal record and is successfully licensed, I've never seen an insurance company deny, sure, you can join our network. We might pay you 50 cents an hour.
Right.
The reason this has teeth is because of this guaranteed minimum reimbursement that we're going to come back to that's included in this bill. So if you're credentialed and licensed and unless they change it or change their criteria to join the network, you know that you're going to be offered a reasonable reimbursement by the insurance company. So you won't be as scared about, yeah, I'm going to get a contract and yeah, the rate will be reasonable because I know what the lowest dollar value will be. So I love it.
I love it too. So, okay. When it comes to like a payment floor, is the hope that, that amount would be enough for a provider in order to, they don't need to go to negotiate. They don't need to think, oh, okay, how do I negotiate getting a higher rate? Would the starting rate be good enough to where you can feel good about just accepting the first one you get? Is that part of the hope?
Well, as practice advisors, we would say no, we're worth more than that, push much higher. Right. But all things being equal, the rate that's offered is good enough to sustain in practice and growth. And shall we talk about that rate, that number, Parker?
Yeah, let's go. I didn't know the actual rate was available. Let's talk about it.
Yeah, well, and so as other people familiar with us know, we really like using Medicare RVU values and putting together negotiations and running your business and planning a budget based on the dollar per RVU you earn as a practice. In a confusing world, this is the most logical way to put together your rates and plan for big growth down to the finest detail, which suits at least our OCD fine detail styles, Parker, I would say. But what it does is it says, so the bill has sort of been referred to as a guaranteed 141% of what Medicare pays. Now, Medicare, our health insurance for people 65 and over, different from Medicaid, which is sort of the safety net health insurance for people with very low income. Mm-hmm. Medicaid does not pay well. And I shouldn't say that exclusively. There are states and other things where Medicaid pays well. But Medicare pays in general well. Every hospital accepts Medicare. Most outpatient practices accept Medicare. The one group that does not accept the most Medicare, it's not plastic surgeons, it is psychiatrists. They are the highest group that is out of network with Medicare, which again shows you a problem. But that being different topic. So base Medicare rates are pretty good, and then mandating 141% of Medicare rates gives you extra that makes it feel fair. Now, these are commercial insurance companies with billions of dollars of profit. More fair would be 2.5, or 3 times the Medicare rate, as we talk about that's where you start the negotiations. But 141%, which the way it's calculated is you have to take the average Medicare reimbursement rate for medical or surgical procedures, so non-mental health, and then you average that with the 75% rate. Let me explain that.
75% rate or 75th percentile?
The 75th percentile rate. So to get to the top quartile Medicare reimbursement. In Illinois, in general, if you look at all medical and surgical clinicians, they're getting on average about 127% of what Medicare pays. So if you go to your primary care doctor, or you see a surgeon, they've negotiated on average 127% of Medicare rates. The 75th percentile, so the top quarter of negotiators in the state of Illinois, have gotten 155% of Medicare rates. This also illustrates, right, this is the 75th percentile. The 90th percentile is probably 250% or 300% of Medicare rates. That's why we should be fighting for that as well. But you take the 155 and the 127, you subtract the difference, which is 28%, and you add half of that to the average, 127 plus 14, that's this 141% number. So that is what you are guaranteed as a mental health professional for the code, CPT codes. And those are numbers that you can run a practice on. For a little, not fully researched, but through word of mouth, often insurance companies offer 80% of Medicare rates to mental health professionals. So 141%, we're almost doubling what the lowest offers are.
Wow. Okay. Okay. This is good news then.
I love it. I want to get a bill like this pushed forward in California. California, the 4th largest economy in the world. There are a lot more dollars working against this. You could see where in the state of Illinois, it may not be as much of a battle just because of population numbers. But in California, word on the street is something like this would be much more aggressively fought against by insurance companies. But
yeah, so
we've got to
fight.
fight.
I'm sorry.
Sorry. Go ahead.
No, I was just going to ask, like, yeah, I mean, is the hope that Illinois can kind of lead the charge, implement this correctly, get the insurance companies to develop some kind of, way of accommodating this in one state and possibly spread it to other states that would like to see the same thing happen in their state?
Yeah, so the hope in Illinois, so this takes effect January 1st, 2027.
Oh,
Right.
that's
So
soon.
it's soon. It took all of 2025. The final vote on this bill was in December of 2025. I think by June 30th, the insurance companies have to say how they're going to report on this and make the change.
Oh,
And then, beginning January 1st, 2027, this needs to be enacted. And the hope, Parker, is that this legislation would show that many, many more mental health practitioners signed up for commercial insurance, that people trying to get care were able to get more care. And if it can demonstrate that, hey, it used to be 50% of mental health practitioners in Illinois didn't take insurance, but now after 1 year, it's only 46%. It's a slow, right, 60 days to get credentialed, contracted. So it wouldn't be a huge drop, but it should start showing more people signing up for insurance, more access to care. And I think once we have a couple years worth of data, that could be powerful to going to other states and saying, look at what Illinois did. Guess what? The insurance companies still made $8 billion. Whatever. Their profits were not really hurt. And we've got to do this elsewhere. Now, the dangerous thing is that people don't sign up with insurances, one, because of poor reimbursement, and two, because of maddening phone calls and other aspects, payment denials, etc. Is paying a reasonable rate enough to overcome dealing with the insurance hassles? Or is it really
doesn't just
more
solve all of the insurance problems? It just solves some of them.
Yeah, and people are still, people in established practices that are maybe full from cash patients because of supply and demand. Well, maybe they don't actually want to take still a 50% drop to go down to 141% of Medicare rates. So if this has no impact, that will give some teeth. We would try to spin it that, like, well, it needs to be a higher percent of the Medicare rate then, and two, we need to have guaranteed, streamlined, immediate payment. We would have to figure it out, but if it doesn't have a big impact, the commercial insurance companies will say, hey, this didn't do anything to improve access to care. This isn't the right bill to do that, and blah, 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 and try to kill it. But
I want to kind of quickly ask about something that you mentioned, how the insurance companies have until June 30th to show how they plan on following this. Is that a standard thing for enforcement? Having them, before this law goes into effect, having them make a statement or report of some kind to show, hey, yes, okay, we are going to follow this? Is that part of the enforcement model, or is that a one-off unique thing to this specific law?
No, that's pretty, you see that for lots of legislation on all sorts of topics around new rules. Yeah.
And the industry's having to report. Okay.
Yeah, and then sometimes, right, so this is where the different states, right, they try to put the burden on the company to show what's happening, which of course people could falsify or make stuff up. And then potentially get, sometimes we create a whole new enforcement branch within the government to try to follow up. What I really want to do, Parker, is similar to the NIMH fraud enforcement, where if you're a savvy researcher and you find that NIH funds were used for fraudulent research, that then you get a chunk when they take the money back from the institution or whomever was awarded the funds. You get a chunk of that money, the individual. So I want to pass enforcement onto people, so that if a person who's trying to get care for their kid, has direct proof that an insurance company has a ghost network, they collect the data, they send it in when it's verified. Hey, here's a big fine on the insurance company for their ghost network, and the citizen who did the legwork, here's 10% of that cut to you. And that's how we could get a lot of people motivated to do the legwork versus a government watchdog entity, and certainly the insurance companies themselves.
Okay, that's fascinating. Okay, well, we've talked a lot about Parity in general. Anything else you'd like to touch on before we wrap it up?
Yeah, I think the other thing, and again, said before, that's very frustrating as a provider, is that we can be aware of all these parity laws and how they affect our patients and trying to fight for parity. But as providers, we have very little teeth in the game. Insurance, the parity laws are written really around protecting patients and patient access to care. Now, that the new law in Illinois might give some teeth to providers, because if they show they're not being offered the mandated rate. Right. But in California, I really can't. I know that these networks don't exist, or there's not an in-person provider. I can't really do much about that. I can yell at people and be angry on behalf of my patients, but it needs to be the patient that's who has the right and the power to actually enact change, which is another BS issue, because these are people who are struggling with mental health issues themselves, or their kid is, and this is that it's hard to find someone with the energy, expertise, and willpower to submit paperwork and fight against an insurance company when you're just trying to help your poor depressed kid, right?
Yeah, mental health is unique in that way, in that the barriers are more complicated than the other medical disciplines, as far as communicating with your insurance company and coordinating with your insurance company and doing something that is difficult and taxing emotionally and mentally. That's the whole reason you're seeking care. So it's not like when I have a toothache, it's hard for me to talk to my insurance, let alone just go call the dentist. But that it's I don't know how. It's just I don't know. That's God. Yeah, that's disappointing. The more I think about that, but I mean, it is encouraging to see that there are states like Illinois that are kind of putting their money where their mouth is and saying, hey, this is something that will help a lot of people. It's not going to solve the whole problem, but if we can see other states doing something similar and taking, good lessons from it, then that does give me some hope. So, the day that we could just see our provider and everything is just figured out and we get a bill in the mail and we never had to call anybody, and it was for a service that was maybe more complicated than your typical service, but it's just the money was clear, then I feel like we can rest easy and feel good about where the world's at. But it's not always like that. So see where it goes. We'll see where it goes.
Keep the fight going. Join our team. Our team.
I mean, Enfermos Tuere, Tom.
Enfermos Tuere. There you go.
Yes, that is our battle cry. And now a word from Rai, our AI mental health practice advisor.
This is Rai, your AI mental health practice advisor. Practice owners often ask, what's the most common billing mistake that will slowly cost my practice money? The most common billing mistake is not creating an easy-to-enforce cancellation and no-show policy. This leads to lost revenue for missed appointments. Remind patients of the policy whenever possible to minimize these losses. For more practice advice, ask me a question at RipsyTech.com.
All right. Before we started recording, honestly, when we jumped into the meeting today, you said, Parker, I've got a business moment. Make sure you ask about it. So I want to hear what is up. What happened? Fill us in. What's your business moment for this week's episode?
Parker, very relevant to this entire podcast, but consistently amazed at this world. So, patient has been seen at the clinic. Insurance change in the new year to a different insurance. California SB 855, but protections to help with staying with your same provider.
Okay.
And historically, this is, sometimes you don't have to do very much to do this, and they'll quickly sort of give you an agreement. But sent the information along for this patient, and then they said a doc that was needed, and which was very frustrating. I sent over a good summary about the case, and if it's a very straightforward and clear-cut case, but I did the call yesterday. The doctor introduced themselves as, "This is medical director so-and-so." I said, "I'm sorry, I didn't catch your name." They said, "We don't give out our names anymore, but here's my initials." And this is the first time, Parker, I haven't been able to get someone's name, which feels like you're so embarrassed. What's the deal?
Yeah.
And because of that, I didn't know that, hey, that's illegal. There's a California statute that you have to give your name and prove you're a real person if you're making a decision. So now I know. Next time I have the California statute memorized, and I'll say, no way. And actually, I'm going to try to get this person's name, because they denied the request, Parker, on the grounds that there were two other child psychiatrists within the proper distance and time that could see my patient in person. And I said, I 100% know that is not true, because I know the Bay Area.
Yeah.
I teach at Stanford at UCSF. And I've recently gotten multiple single case agreements because no provider exists within this area. I said, tell me the names of the people, and we're going to Google them right now, and I will show you that there's no such provider. And the doctor would not release the name. He'd say, well, that's not, the insurance company said this was true. We're not going to get into this. I think maybe claim they didn't have the names, which previous doctors have had the names, and just sort of shut it down. And it was very frustrating, because we're trying to get proper care for my patients. Another board certified child psychiatrist is denying it. And then how hypocritical to say, I empathize with you. And I said, don't do this job. Don't tell me you empathize with me. Don't do this work. I was really losing my mind. But Parker, this morning, the family sent me the names that they sent them, as saying one of them is a non-psychiatrist addiction medicine doctor for adults, that even then it does not, it's going across the Bay Bridge. It might be within the miles, but that is not within the limit. But it's not even a psychiatrist. And the other one is a nurse practitioner. So it was BS. As I guarantee this person, there is no other child psychiatrist that has in-person availability to see this person that meets guidelines. And it is maddening. It is maddening. And the worst thing, Parker, is that for anyone, to take the steps to like complain to the insurance company, they sort of mandate you to go through the insurance company's appeal process once. Right. Insurance companies then have 30 or 45 days. So this is what happened to another family of mine where the appeals process took them out of care for several months, and it hurt the whole treatment. Mm-hmm. And it is unacceptable. It is unacceptable. I am most ashamed of my own colleagues, my physician colleagues who are here to try to help people, denying care for my patient. And anyway, I'm outraged. But
I can tell.
Yeah, the fight will go on. The fight will go on. Unbelievable.
That is unbelievable. Actually, that it's like, the facts. You know exactly how it is. And I mean, I think this kind of just fits very well into kind of what I was saying earlier. It's like they can do the wrong thing and without really needing to take too much accountability for it, because for them it's all going to shake out just fine. They can function embarrassingly incorrectly, I guess, and it's fine for them because they're this too big to fail giant health insurance conglomerate. So even if they waste your time, it doesn't really make a difference to their bottom line. But you still need to fight with them in order to get this patient the care that they deserve. And it's just, it's mind-blowing that the insurance companies wouldn't think that they feel some semblance of responsibility to make that happen. And the fact that this person would not release the names to you when previous doctors on other phone calls have released the names to you, and the patients are just going to end up with those names anyway. And then you find out, hey, this is not appropriate for this family, and it just further wastes everybody's time. Meanwhile, a patient who really needs help is just getting nothing. So, I'm frustrated for you. I really am. That's.
Yeah.
I feel like this. I feel like I'm gonna be telling this story to anybody who asks me, like, "Oh, what do you do?" And what are your thoughts on health insurance? I'm gonna be like, "Well, actually, yeah, that's crazy." That's frustrating.
Yeah, but we're optimistic. Fight for what's right. There are reasonable people and victories that come around, and that's what drives our company and trying to empower people to deal. We're not being very convincing on, like, hey, work with insurance companies, but
I know
there are victories.
So yeah. I meant, like, especially, I mean, mental health visits can be very expensive out of pocket. I mean, just not taking any insurance, just paying cash, and I mean. We live in a world where it's designed to make it hard to do the right thing sometimes, and it's just a letdown. Anyway, how easy is it to move to Illinois, I wonder?
Gotta love Chicago. Yeah, and as you know, Parker, I'm getting more involved with CSAP, California State Association of Psychiatrists, and I'm going to start it. I've been resistant over the years because the political system is another complicated piece, and it's a long game. But that being said, there are very good people fighting on behalf of the patients in California, and I need to do more on all venues. So go at it from all angles, and hope for the California bill that pays every mental health professional 160% of Medicare at a minimum.
There you go. All right, Tom. I would say this is a great place to wrap it up. That's it for this week's episode. Please leave a comment or follow wherever you are listening to this podcast. If you're on Apple Podcasts, please leave a rating or a review. Spotify, tap that 5-star rating, and on YouTube, like, comment, subscribe. All of those things really help out our little podcast, and we want as many mental health providers to get exposed to the material that we are putting out there. So if you found this useful, please do one of those things, and it might just fall on somebody else's lap and change their career. So yeah, we appreciate that. And if you want to get in touch with us, please send us an email at sitandstay@ripsytech.com. All right, Tom, it was great, and I will see you next time.
See you next time, Parker.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at RipsyTech.com.